if somebody's on a psychiatric drug, I think
Speak up, please.
Sorry. If somebody's on a psychiatric drug, a serotonin drug, I guess, how do you phase it out? How do you get rid of it?
I'm not hearing you. I'm sorry.
If somebody's on a psychiatric drug, a serotonin
I think
receptor
it's
inhibitor,
serotonin.
how
I'm
do
not
you
sure.
phase it out? Am I getting it right?
Yes.
Okay.
Well, it's a good question, and you'll see it's consistent with every way I approach things. The main thing is to, if it's no emergency, is to go at the pace of the person who's withdrawing. All the big mistakes are the doctors who say, oh, you want to come off the drugs? All right, half them to this week and half them the next week, and that's it. They're often punishing their patients with good intentions, of course. But I'm going to tease you forever. But first of all, I build a relationship. Because a person who's coming off drugs is going to go through potential problems. Then I help them build relationships with other people. And I won't withdraw somebody who's in a lot of trouble and has nobody to be with them at night. I just don't know how to do it. I had a private practice. If they could go to a hospital, it's not usually possible. So I help them build a community around them as much as possible. I'll even talk with a member of the family, actually, and tell them what the adverse effects on withdrawal might be. And I'll give my cell phone to that person who's withdrawing, and I'll give my cell phone to the person who's living with them or calling them and so on. And I tell them that the reason you failed before and the reason you're so afraid, because those are the people who come to me, the reason you're so afraid is it wasn't under your control. And the way I'm going to help you put it under your control is I'm going to give you the tiniest possible reduction the first time as I can figure out to do with you and how much you break up your pills and whatever. And let's see if you can just do a little withdrawal and it doesn't affect you at all. Give your confidence going, get your hope going, and we work it out. And by the way, I got a whole book about it, psychiatric drug withdrawal. And so you go slow, and then you have I don't want to get into it tonight unless asked, but you get into the complexities of which drug, if there are several drugs and all of that. In general, you want the sleeping pills to go last because when people have to deal with insomnia, that just wrecks everything. And basically, I try to help them get rid of the antipsychotic drugs first because they're so horrible to the human being. But it's basically a collaborative effort with support around them in which they go slow enough to go at their own pace. So literally, my job is usually, well, you want to go that fast rather than pushing it faster. And then I don't get mad if the person says, this is going well, doc, and I have to tell you, I stopped them all yesterday and I'm doing fine. And okay, I don't get mad. I say, well, it was under your control. And if they get messed up when they do it, I say, oh, it's okay. Learn from that. So it's a relationship where you're really helping the person along at their pace. They have to have the power. You want the person to feel in charge, and it will be their first time in their lives, possibly, that they felt in charge with a physician, and definitely with a psychiatrist.
We'll take a question from this side, and then we'll come back here. Yes, sir.
A microphone. It's dangerous to put a microphone in my hand. So my mom is 96 and a half. And until she was 93, took care of all of her own ADLs. She slipped and fell outside on her own and had a traumatic brain injury. So she's been on Seroquel and Aricept since she got out of rehab. While she was in rehab and involved in activities, she seemed to be doing better. Is there anything that can be done for a patient like her at this point? She goes in and out in terms of cognitive ability.
First of all, I won't speak to the Aricept. Maybe I'd like to see you two do that. Seroquel is a terrible toxin and should never be given to anybody who has any form of brain compromise because it will increase the odds. And how old is she? Well, she'll probably die very quickly on Seroquel. And there are warnings not to give any of these drugs.
Black box warning.
Well, she may be, but I can tell you that the science on this is horrible about the rapidity of death on elderly with dementia, so much so the FDA has a black box warning for all these drugs. So she should get weaned off Seroquel. I think I can say that without practicing medicine. Look at the black box warning about that. But this happened to my mother-in-law, Jean, and she lost a lot of cognitive function acutely at 94 when she fell and had a concussion. She already had some compromise. And we found that just loving the heck out of her and surrounding her with people, Medicare paid to bring in somebody to do strength training at her age. They paid to bring in briefly rehabilitation of all kinds of different people. The main thing was she loved the people, and she actually got stronger to prevent more falls. So a huge amount can be done with the elderly in terms of bringing in services, bringing in love. And the main thing I did was what I've been talking about. It's just everybody needs the same thing, I think, in human services. I just told her she's got to have hope. Hey, Mom, you don't have hope. Where are we going? You got to have hope. You love me. You got to have hope. You know, and I'll do that with my patients too. It doesn't cause guilt. It causes a sense of being wanted. And we just got really involved with her, and she's been, so far, thank God, really doing well. But that could change momentarily. I don't pretend that it couldn't.
I fully agree with everything you said as far as medicines. That antipsychotics, 93, it's a black box warning. The mortality rate goes up, and then they attribute it to something else that caused it, but actually it was the cause.
Yeah.
Aricept doesn't do anything. So we wrote in the book about islands of consciousness. Can you hear me? Okay. If I get any closer, you're gonna get so. So islands of consciousness. We have these islands of awareness. She told me right away to be brief, so I'll try to be brief. So we have these islands of consciousness that we build. If you're a musician or music teacher, that's one of your big islands. Family is a big island. If whatever you did is a big island. We had a patient that had dementia, then got UTI for 4 months, had not spoken. We went to her, I did rounds, I went to her and I said, Miss Collins, that wasn't her name, I will just use that. Miss Collins, talk to me. And the residents were getting irked, like, she hasn't spoken in 3 months. I said, Miss Collins, I said, repeated this. I said, tell me about her. They went and the research came back, they said she was a music teacher for 60 years. I said, Miss Collins, again, no, nothing. Miss Collins, who was a better composer, Mozart or Beethoven? No response. And the residents by now are getting very irked. Miss Collins, who was a better composer, Mozart or Beethoven? And all of a sudden I see a flicker. And she, in a very soft voice, says, what a stupid question. She didn't come back to normal, but that was the beginning. Music in the background, talking about music, bringing her students and everything else. There's a lesson there. That was a big island. What is island? Island of consciousness, all the elements that connect to that thing that you're familiar. Familiarity. Familiarity brings more consciousness. Familiarity brings more connectivity. Familiarity brings more awareness. So more Aricept does nothing. And the antipsychotics, all of them, they're sponges. They're dopamine sponges. They're basically going in and sponging out dopamine. So how could that be really good? Yeah, it does silence the mind, but it's not going to take a 93-year-old to awareness. What will bring a 96 or 93-year-old into awareness is awareness around the things that she was aware before. Build those islands again. Bring familiarity around her again. And what's the biggest familiarity? Love. What's another familiarity? After language abates, even after all language abates, guess what's left behind? Music. This is not soft concepts. It's written in many papers, repeatable papers. So that's how you bring people back, not with antipsychotics or Aricept. Finally.
Okay.
Good evening. I have a question. What are your thoughts on commonly prescribed drug Wellbutrin, especially considering doctors normally prescribe it for quitting smoking? And wouldn't be benefits of quitting smoking outweigh like outcomes of and danger of Wellbutrin?
Can you repeat the question? The drug?
Wellbutrin.
Wellbutrin.
Well, and Shantex, yeah.
Wellbutrin for smoking cessation.
Well, and Shantex, I can address that, you can address that. Shantex is the drug that produces probably the most abnormalities in the mental sphere of any drug that's been studied at the FDA. A paper by Thomas Moore found that Shantex was the most associated with violence of all of the hundreds of FDA-approved drugs, right at the top. And it was interesting to me because, those are pretty normal people that the drug is driving over the edge, but they are also going through withdrawal from cigarettes. So Shantex is a very dangerous drug. And when a drug makes people violent, it's making them do lots of other things. Violence is just one expression of aberration. And Wellbutrin is a very stimulating antidepressant. We shouldn't even use words like antidepressant because they don't do it. But it's a very stimulating neurotoxin. So it can produce the whole array of things: suicidality, aggressivity, and then there's a litany of the amphetamine-like stuff that's in all the labels: the agitation, the anxiety, the impulsivity. It's an activation that actually came out of one of my papers, practically right into the label. It's very amphetamine-like. So the smoking cessation drugs are really poor, and again, the triad of exercise, nutrition, and some spiritual coming to grips with it is probably certainly a lot safer.
Absolutely. I'll take a question. You had your hand up. Microphone, please. I can repeat your question if you want.
Hello. As people age, their renal clearance goes down, and they're put on these drugs with increasing dosage to get more symptomatic effect. What happens to a patient when their renal function declines and they're on like all three Alzheimer's drugs at the same time?
So the question was about renal clearance and the effect of medication on somebody who has renal clearance issues, where they can't really clear off the byproducts of medication and what happens. So there are different medications that get processed in the body in different ways. Some of them get out of the body through the kidneys, through the urinary, through the renal system, and then there are medications that are processed by the liver or the hepatic system. And obviously, the ones that affect the renal system, they get toxic in the body. A lot of medications that are used for seizure prevention, that are used for diminishing consciousness or abatement of anxiety when it's related to Alzheimer's disease, can cause a lot of damage as well. So that's why it's very important to find out the baseline of the patient, where they are, whether they have any renal issues or hepatic issues, and then deciding, not to give them a lot of medication to begin with, being more lifestyle related. But if you have to choose somebody, it has to be, if you have to choose a medication, it has to be based on their baseline kidney function and hepatic function.
And liver is very important. You've stressed the kidney, but most drugs, I think it's fair to say, are detoxified in
Correct.
the liver. So it's the liver function that you also really have to look at. With psychiatric drugs, other than lithium, I can't remember offhand one that isn't detoxified primarily in the liver.
Right, and Keppra, which is used for seizure prophylaxis, is processed by the kidneys too. Yes.
If you were to diagnose early Alzheimer's in a patient, would they have to go to a neuropsychologist? That's one question. My second question is with sunshine, obviously people are using sunscreen so they prevent melanomas. So you suggesting like a low, less, but not to wear 50, to wear maybe less of a sunscreen to get the sunshine?
You can use sunscreen. I'll do the. So early onset Alzheimer's. If you've been diagnosed, this is the third time I got that question today. There aren't that many of those. So be very careful. If somebody gets diagnosed with early onset Alzheimer's, you must go to a neuropsychologist and go to a clinic, a academic setting, because it's misdiagnosed. A great number of times it's misdiagnosed. It could be severe depression. I mean, depression by itself, because attention is the gatekeeper of consciousness. Anything that affects attention is going to affect memory. And depression can get so bad that you can't focus to the end of the sentence. Therefore, they're going to diagnose you as dementia. So they're going to put you into that whole pathway. And there are a lot of other things that can cause early cognitive decline. B12 deficiency, thyroid disease, infections, lots of other chemical. So it should be diagnosed, it should be evaluated, it should be evaluated through a neuropsychologist in a good setting, because I would be quite incredulous of that diagnosis unless it's been through a good setting, a good venue. Yeah.
My guess would be that the vast majority of early signs of cognitive dysfunction are psychoactive substances, and they may not necessarily be psychiatric drugs. There's plenty of other drugs that cause cognitive problems, and that probably the most common cause of early.
There are medications that cause it. There are substances that didn't affect you before, but now with aging, you're going to hit that precipice. I've written this thing called the precipice phenomenon. Yeah, you know, you didn't get to the precipice right away. You walked to it. And then there was a precipice. You had a UTI. You ended up in the emergency room and disoriented. Oh, it's the hospital that did it. No, it was the precipice phenomenon. So the pharmaceutical component, the medication, the psychoactive stuff, depression, anxiety, lots of other things have to be ruled out before you're giving the diagnosis of early onset Alzheimer's.
Okay, right here.
Hi, I have a friend that's a big fan of yours, Dr. Breggin.
I'm having trouble, so speak up.
Big
I'm
fan.
having trouble too, apparently.
Okay, he's a big fan of yours. He's been off psychotropic medication 4 years, but he's describing agitation on a daily basis and 2 suicide attempts. Trying all those wellness, nutrition, acupuncture, a good support system, doesn't seem to be working. So what's next steps when the wellness strategies aren't working and they're in the suicidal ideation, do not want to take medication? What other alternatives then are your next steps with this?
Well, first of all, there's all of life, and I really want to emphasize that. People find their way through so many things, religion and God and their pets, really their pets, often nature, a friend. I mean, there's so many things that pull a person out. But looking at it just psychologically, people who go from one place to another for help and don't get help have reasons for not getting help. So the thing to address, and well, I don't know what all of that means. Agitation, anxiety, I don't know what it means. But I can address the idea that this person goes a lot of places and nothing helps. I can't address why she might be agitated. She might be agitated because she's subconsciously remembering child abuse, or the person that she knows who you think is loving is beating her. Who knows why somebody's agitated? But I do know the pattern of nothing helps. And nothing helps has to be addressed on the level of what is keeping you from taking charge of your health care. What is keeping you from facing things and doing them? There's some benefit, in your mind about this, and you have to be very loving about it. You cannot undermine, so easy to undermine somebody, and nothing undermines people faster than saying, it sounds helpless to me. So I've avoided that one, except when I'm not on my toes. But you want to help the person see that there's something more going on here. And it's often a plea for being rescued, that comes out of the child's mind. For God's sake, please, somebody. And I'll explain to people that the worst thing you can do for yourself is be helpless with other human beings, because they can't bear it. If you go to somebody and you tell them no one's helped you, and you go to finally somebody's going to call a psychiatrist or something. because human beings get very distressed when people just won't respond to anything they do, to that kind of helplessness. So there's a kind of an interesting thing to look there. May not be relevant here, but it's relevant to all of us, because we all at times wish we could just say, it's so bad, would somebody come and help me? Now, in my case, it's wonderful because Ginger either says, stop being helpless, or she says, here I am, depending on her mood.
We'll take a question from this side. Yes, ma'am.
You talked about high blood pressure and the effects on Alzheimer's. What about low blood pressure?
So low blood pressure in the setting of calcified arteries is a bad thing. If somebody has had atherosclerosis, which means hardening of the arteries or narrowing of the arteries, especially in the neck and in the back of the head, that is essentially the major arterial supply to brain. Say, for example, if somebody has had narrowed arteries and you figure that out late in life when they already have cognitive impairment, you don't drastically lower down their blood pressure. And low blood pressure can actually cause fogginess and confusion, so you tend to keep their blood pressure high. But that all depends on how clogged the arteries are. Once these reverse, and we've done that with lifestyle, so on and so forth, everything that we talked about, then it's ideal for blood pressure to be low because, you know, we have millions and millions of arteries the size of your hair that supply billions, not millions, billions. That supply oxygen and nutrition to the brain. And, you know, these collapse. These arteries actually collapse on themselves when blood pressure is very high. So, you know, the day we find out optimal blood pressure for every individual is when we will make major changes in healthcare. I cannot wait for technology to actually help us ascertain that.
We are doing blood pressure is a terrible chronic
It's a really
disease.
blunt way, yeah.
We have no tools of really truly addressing blood pressure. It's not just high blood pressure or low blood pressure, because both can be bad.
Yeah.
It's the high blood pressure and low blood pressure in the context of your previous pathologies. And how are we addressing it now? Every 3 months, taking a blood pressure measurement in a clinic, and then your medicine's adjusted according to that, which it doesn't get any more blunt than that. So we're doing a poor job. We say one of the best things you can do is to take a blood pressure measurement at home of yourself, maybe even twice a day, and write it down, and then take it to your doctor. Make sure that the tools you're using is valid and is tested to it's accurate, and then you take that to the doctor, and then they can make the adjustments. Not once every 3 months at a clinic, which means nothing.
I'll take a question from this side. Yes. Oh, I'm sorry. Sorry.
Wait,
I
hello?
apologize. I'll get back to you soon.
Oh, hi. Regarding drugs, I have a dear friend who's been, like, I'm sober 27, clean and sober 27 years, so I don't do anything, which is really hard. It's a lot of work. And she is overweight, and she has started taking, through her doctor, which will give her anything, amphetamines. Now, I always heard the expression speed kills. And she's like very stubborn. She even suggested, because I'm kind of naturally hyper, oh, you should go on it. It's really great. Helps you focus. And so I know that's not what I want to do, but why are amphetamines so bad? That's what I want to know, the science behind it.
Why are amphetamines so bad? Well, first of all, they don't help you focus. They shut down the rest of your brain so that you're able, with what you have left, to focus on something that's stupid and boring and you want nothing to do with. They wreck imagine, you know.
That's beautifully stated.
Thank you. So it's over-focusing, and we give children Ritalin, and, you know, they bear down on the paper and it tears. There have been studies of this. It's actually OCD. It's NIMH did the only study that ever looked at this, and half the kids on, I think it was simply methylphenidate, developed OCD during the process. And interestingly enough, about half of them got tics when they started really looking. So there's something going on with those basal ganglia that have a lot to do with OCD and tics, and they're all being stimulated by at least by the dopamine effects. The other thing that the drugs do is they limit spontaneity. They may drive hyperactivity, but the person loses flexibility, loses the ability to think. One professor said to me, nobody writes a good paper on Shakespeare when they stay up all night and do amphetamines. There's something very rote that's going to come out of it. Beyond that, we have studies that the amphetamines shrink brain tissue. I mean, they do. And the studies start with the methamphetamine studies because that's what people are willing to do. And then it's very interesting, but not evil, when the studies come out for Ritalin shrinking tissue, they explain how it's helping. Really interesting. I see 2 studies out of John's.
That one is evil.
That's evil, right? It was, listen, you find these buried somewhere in my books. Amphetamines, they really do. They're not good for the brain at all. And they can produce violence and they can produce mania. And a person that is that hyper is in serious trouble. They get that hyper with somebody on the street and they're going to be in trouble. So they're terrible drugs.
And one little other thing, seizures.
Seizures too, yes. Thank you.
Oh, I'm sorry. Okay. Just don't trust me. It's too late in the day. I'm sorry. Go ahead. Yes.
He wants a job. Give the man some
I'm sorry.
autonomy.
Go ahead.
What's an absolute and safe way to remove heavy metals from the brain?
I couldn't hear you.
What's a really reliable, really effective way and safe way to remove heavy metals from the brain?
By not taking them.
No, but once they're in from whatever it is, mercury, whatever, what they've been measured, it could come from the dental mercury.
So you're talking about the process of detoxification. Chelation and detoxification have been studied, but not broadly. The body has its own internal mechanisms to get rid of toxic material if you give it the chance to. A lot of the chelation studies that have been done on copper and other heavy metals are done in the context of acute heavy metal poisoning. There are no studies that have actually looked at people who, say, for example, eat a lot of fish and then they have deposition of heavy metals in their neuronal tissue and they did something to get rid of it. If you don't produce toxic material to the body eventually gets rid of it. I hope that helps. It's not very exciting.
Something I'd like you to address is, how does this gentleman, how do you know you have a heavy metal problem in your brain? Because I'm not sure how we would know that, or whether it's somebody who did your saliva or your hair and came up with this. So I think you should look at, is that reasonable? You should look at, where this come from, this conclusion.
How do you know you have heavy metal toxicity?
Or even if he does, he may have spoken about somebody else.
Or somebody else?
Well, because I did some heavy metal detox and I got better to a certain point. And then what I was taking, they stopped manufacturing it. And then twice I tried something else and I got really, really bizarre symptoms. I might have taken too much. Once it was like the vision field was digitized, little pockets of things pixelating, all kinds of crazy things. I don't know what was going on. Another time I was taking one that had EDTA in it, and obviously it was too much, but I took it what I was advised, and suddenly, I called somebody, he said I already called him 5 times, for help. So, of course, I stopped. So that was, the whole thing of correlation isn't causation, but that's pretty clear to me. And I'd had a lot of amalgams in the past. And also, it might have been not heavy metals. I was in India once when they were, they're spraying this big camps with, what was it, that's some pesticide that's banned here. So I could have absorbed who knows what there. But that's how I got to it. And actually the first clue was an intuitive doctor that this big clinic down in Washington, the doctors sent all their really difficult patients to this intuitive MD who'd gotten hit by lightning and became intuitive. Okay. And I called him and he said, "You're so loaded with heavy metals, I can't see past whatever else is going on." That's when I started the detox and started getting better.
Okay, that intuitive doctor thing threw me off a little bit.
Yeah, but the consequence of my doing it got me better.
So I don't know if I want to address all of that, but so I'll address the core concept. Heavy metal toxicity. Is there such thing as heavy metal toxicity? Yes, mostly from foods. There's not much evidence that dental caries and things or dental appliances cause heavy metal toxicity. There's not much data there. So if you suspect it, have all of these tests that you're hearing about for gluten, for this or that. Do it in a legitimate setting, in a setting where there's not an intrinsic bias towards finding an outcome, because they will find an outcome if they want to treat it. So heavy metal toxicity, and I have the lab that actually looks at people with potential toxicity. In years and years, out of thousands of people, maybe I found 2 people that had slightly elevated mercury levels. So it's much more overstated than is truly out there. So, and then get it appropriately tested. And then the other thing is, the idea of if you think you're toxic and then using the medicine as a way of seeing if the original disease was true is actually a little bit of a backwardness, because you will find the thing you're looking for, even if it's there or not. So be careful about treating diseases without even truly finding out if you have disease or not, because then you're going to be the subject of your own experimentation forever until you kill yourself. So it's really important that you get legitimate testing and truly get diagnosed and treat it only when you need treated. Because simple lifestyle measures work so much more. I think that's a good broad way to approach that.
I'm sorry.
You've been picked.
Yeah, you've been picked. No, he had his hand up for a while. I apologize.
Him or her?
Him. And then we'll come back to you.
Hi, thank you for being here. From what I understand you saying, there's no reversal of Alzheimer's and the onset of dementia once the plaques have formed, and the drugs...
Can you speak a little louder, please?
Sorry. From what I understand you saying, there's no reversal of the onset of Alzheimer's and dementia and reversal of the plaques once they've formed, and the drugs don't delay the progression of the disease. How is it that your Alzheimer's solution then helps once the condition's been presented diagnostically?
Well, the first part is not controversial at all. There is nobody ever claims that there is reversal of Alzheimer's. And our book never says we're reversing Alzheimer's. It's a solution for developing Alzheimer's so that you don't develop Alzheimer's. And that's big enough. You know, that's, if we can, look at this. If we can move Alzheimer's in the population back by 5 years, we will have reduced the cost of Alzheimer's to society by half. That's a pretty good measure. We never want to make hyperbolic statements.
Okay, this crowd.
Let's make this the last question, then I'll ask everyone to make a final closing statement. So,
Okay. Let's pick you, sir.
Is the brain made up of essential fatty acids or a lot of fatty acids or fatty material?
Brain is made of a lot of fat.
Okay. Would fish oils be good for a brain?
Fish oils would be good for the brain, yes. But it's better from, like I said, from algae form, because where do you think that fish get the omegas?
Or essential fatty acids?
Yes, absolutely. But there's some people making these claims because cholesterol is not bad, fat is not bad, because your brain is made of fat, so therefore you need fat. It's the dumbest thing I've ever heard in my life, and I want this to go out there. It's ridiculous how that analogy is being made. Just because your brain is made of fat, therefore you need more fat. Your brain also has a lot of iron, so you should be biting on iron. I mean, that's kind of a... So a fat in a proper way, in whole food way, in a polyunsaturated way is absolutely beneficial, especially in omegas and DHAs, yes.
Okay, so you've all given your individual lectures. We very much appreciate you coming here. Would you like to leave us a summation of final thoughts encompassing any final important pieces of information or conclusions you'd like to share with us tonight?
Why don't you start?
I'll be short, believe it or not. I think, first of all, thank you so much for doing this. It was a very different kind of experience. We've been in dozens and dozens of formats, and this is the one that I feel a little bit of tension, and I like that. That's the way it should be, because if you're going to get to true health, you got to be a little bit tense, and people, so that's beautiful. And I learned.
Not tense.
No. I meant it was great. I learned so much. And
I actually thought it was great too.
Yeah, I did. I
did.
promise
That
you.
was an amazing beginning.
I'm reading every one of his books.
The first half hour here was the most exciting half hour I've ever had on a panel, and it was just amazing. Wonderful.
And I will definitely read every one of your books.
I already bought yours.
So I really think that most of health, not all, most of health can be achieved in the community and at your home through community, through whole foods, through exercise, through good sleep, and social mental activity. That's 90% of all health. If you just focus on that, you don't have to buy my book, his book, nobody's book. That's true health. And you will avoid all the side effects that are being hidden by the evil industries.
Well, I'm honored to be here. I truly am. With all the work in the hospital, as a resident, as a physician, during fellowship, I'm more passionate about sitting here in front of you asking me questions, and me trying to answer them to the best of my capacity. I'm very, very passionate about public health. So, Steve, thank you.
Sure, thank you.
For creating this opportunity for us to disperse information about real truth about health to the public. I think as far as summation of everything that we've been through, I've learned that truth comes out in dialogue. We should have more of these opportunities where we can discuss health measures and preventive measures in a very educational, comfortable, sometimes uncomfortable, but mostly comfortable and challenging situations. And the message to the community is, don't wait for a governing body to tell you what to do about your health. We all know, we've known for a very long time how to live a healthy lifestyle. And it's never too early, and it's also never too late to start it at home. And that health actually starts at home. The decision you make what to eat, the decision you make when to wake up and how you go to sleep and how you walk, all of that makes a significant difference in brain health, as simple as it may sound. So thank you, Steve.
Thank you.
I had a wonderful time, and I learned more from you too than just about anybody I can remember about whole bunches of things. And I'm actually going back home to deal with my mom, my wife's mom, in better ways, and I'm grateful for that. And I really enjoyed your willingness to have me intervene and make a statement and work it through and all. It was really great, and that first half hour I think is priceless on film. And one thought to leave you with: I like to think about how we evolved and use the standard of, well, what in the world made sense for 2 million years? What made sense for 2 million years from when we climbed out of trees and got here? And we were eating plants mostly. There's no cultures except for Eskimos and a few others that ate a lot of meat. And it's so clear we are basically vegetarians who scramble and get a little meat usually when we can. And the second thing is we had to move. We moved or we died. We were nomadic. We were on our feet. The women were out gathering. The men were out hunting. So we got to move and we got to eat well. And the communities for 2 million years were around families. They were not villages. It doesn't take a village to raise a child. It takes a family to raise a child. And I'm good that resonates. And what it really takes is a family to help a mother raise a child in the early years, and then to help a mother and father raise a child. And to be nursing, we didn't deal with that, to have mother's milk in the beginning. So think about who we were when you want to know where we're going. And we lived in relatively loving communities, though toward ourselves, maybe not the other communities, but toward ourselves and toward our children. And it's all what we're doing now. We're rediscovering and learning what human beings are made of, and we're made of good food, activity, and lots of love.
Very true.
Thank you, Dean, Ayesha, and Peter. We all appreciate it.
Thank you.